Once again, we're here for another episode of the Osteopathic Lyceum podcast. What we're going to do today is build on the conversation that we had with respect to my claim that osteopathy is essentially devoid of theory and primarily has hypotheses that are consistently shown to be null or shown to require rejection. So there's a lot of hypotheses that are colloquially termed theories, but realistically they don't meet the criteria of a theory because they have not withstood testing to increase confidence that they predict observable reality appropriately. So we want to extend this by noting that when a concept is built on something that has a notable flaw in it, or a hypothesis that has a notable disproved portion, or a notable portion of it that is shown to not match observable reality consistently enough to make it useful the way you want, then everything that's built on top of it contains that flaw. Okay, so we want to initially point to the Fryette model of coupled spinal mechanics. Primarily, the initial portion of the Fryette model was built in the thoracolumbar region, so in T1 to L5. The Fryette model initially described motion from T1 to T5. There was another description of cervical coupling, cervical coupling from C2 on C3 down to C7 on T1, as well as the head on C1, or the occipital-atlantal joint. There's different ways I think that people break that out. Occiput on atlas, occipital-atlantal, there's different ways to say that. But anyways, there was subsequent building of that model, and then subsequent to that, Fryette's third ended up being done in, I think, 1948. That's a little bit of extraneous information that's not absolutely required for the conversation, but we'll put it in there anyways. So the Fryette model essentially holds that when the vertebral column in the thoracolumbar region is in a relative neutral position, so neither heavily flexed nor heavily extended, depending on the region that you're in, when side bending occurs to one side, rotation will automatically occur to the opposite side. Now, I haven't seen a proper description as to whether or not this is an automatic thing, or that when you find it in this abnormal position, the other one automatically exists. The other thing is that this is built off of primarily cadaveric specimens, I believe. So it was essentially isolated vertebral columns, possibly with some level of anatomy intact, some level of anatomy removed. So this was dead bones being tested for relational motion, for what happens in one plane and the other plane when you do this, that, or the other, or what happens when I add in the third plane of the sagittal. So it's essentially, you start with your coronal claim, then you give or actually when you write it out, you start with your sagittal finding, so extension reflection, so you'll see E or F, then you'll see SB for side bending, so that's your coronal finding. So side bending right or left, and then you will see R and then L or R, so rotated left or right. So that's your transverse plane finding. So it's, as it's noted, generally sagittal plane, coronal plane, transverse plane is what you tend to see. But this was identified initially by Fryette primarily in cadavers. Now, the assumption that you have to make is if you have a finding in a cadaver, that is consistently observable in the living specimen. So you have to make that assumption. Now, if you test it in the living specimen and it does not stay stable as an observation, you have to reject your hypothesis. Your model is moot. Okay, so we'll take you through some stuff here that essentially shows exactly this. So I'm going to share my screen. So for those of you only listening, you won't necessarily see this, which is totally fine. So I'll do my best to describe it. Okay, so the first one we have up here is a paper, the evaluation of osteopathic principles in cadaveric specimens using radiological assessment. So you know that this is done in the cadaver, you know that there is radiology, and you know that there's osteopathic principles, right? So the title gives you at least some idea of what the heck is going on. So when you look at it, I'm going to the materials and methods. The study was that's the review board. I don't need to do that. I want to tell you what they did and what they did it on. So fresh refrigerated cadavers were palpated for lesions at the T8, T9, and T10 levels by residents and attendings. When they say palpated, unfortunately, there's no further description of what that palpation means. Did they just look for static asymmetry? Did they use overpressure to test motion in the coronal, sagittal, and transverse planes, or did they just palpate for asymmetry? There's no appropriate breakdown that I've been able to see. Maybe I just didn't read it properly, but essentially there's palpation and a diagnosis, right? These are fresh, refrigerated cadavers. So the assumption there is that a fresher cadaver is going to maintain something closer to its living characteristic. The fresher it is, also it's refrigerated, so it's not necessarily decomposing at the same rate. So again, you're trying to maintain, hopefully, something approximating the living specimen. Maybe it did that, maybe it didn't. But we know that these are things that have to be correct for us to build on it. So if we're going to test it in a cadaver, we have to trust that the method of palpatory diagnosis is what you would want to see to identify these problems. We have to trust that there is, or assume that the fresh cadaver is so similar to the living specimen that we would find the same things, that we wouldn't pull this out. So what they did is they did that palpation. They were looking for agreement between practitioners. They were looking for agreement between the noted diagnosis and what they found with further dissection and further imaging. What they did was essentially they had their diagnosis, and then they confirmed that in varying ways with varying methods, which seemed fine enough. And then when they take the vertebral column back to neutral, it corrected the lesion, or it corrected the coupling, and it made it more neutral. So from that, you're going to be able to make the claim, or you hope you're going to be able to make the claim, that OMT works when we take it out of this asymmetrical position because of this coupling, and we put it back to neutral, it goes away. Now, I would argue that that is primarily a static thing. Static findings don't always relate appropriately to what you find in a dynamic test or a movement-based test. And I've argued many times that osteopathy is primarily based on motion testing. Asymmetry could just be differences in the shape of anatomy. We know this as a consistent feature of all human beings. Paired anatomy tends to be at least mildly asymmetrical, especially across a lifespan. So there's a lot of assumptions that have to be accepted as correct for this paper to come to the conclusion it claims that OMT works and removes asymmetrical presentations in fresh cadavers. We don't work on cadavers, we work on living people. So we have to have that assumption that the cadaver and the living specimen are so similar that the findings generalize, and we don't necessarily know that. Okay, so that's that first paper. This thing is always a problem for me when I'm trying to get this done and switch between things. There we go. I think I figured out a better way. So now we move over to another paper. Now this is not necessarily specifically a paper. This is by please excuse me, by Gary Fryer. This is from 2011, Muscle Energy Technique and Evidence-Informed Approach. And this was actually in the International Journal of Osteopathic Medicine. So this is a paper, because what it says is it's the official version, or like the accepted version. Sorry, let me come back to where I was. Okay, so this is what we want to see. This is in section 3.1.1, which is assessment of the spine. So this is related to muscle energy. Okay. The traditional paradigm for diagnosis and treatment is mechanical, where multiple planes of motion loss are determined and each restrictive barrier is engaged to increase motion in those restricted planes. Identification of motion restriction has been based on the spinal coupled motion model proposed by Fryette, which describes two types of coupled motion restriction, blah, 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 blah. Okay, so we've already kind of touched on what that would be, what that would look like. But what you see is that the muscle energy diagnosis, and subsequently within muscle energy, because that's from Fred Mitchell Sr. Fred Mitchell Sr. is the one who generated the most commonly used approaches to sacral diagnosis, which is the Mitchell mechanics, or the Mitchell mechanics model of pelvic and sacral diagnosis. That may be a funny way to say it, but for Mitchell to be correct, for muscle energy and the Mitchell model of pelvic and sacral dysfunction to be correct, Fryette has to be correct. We've already noted that working from a cadaver to a living specimen has a lot of assumptions built into it. We've also noted that, at least with the study that we showed you just now or just previous, that we don't understand necessarily what they meant when they said palpation. We don't know if they generated motion or if they just looked for static asymmetry. So that's another assumption. For this to generalize, the cadaver has to match the living specimen, and the type of palpation has to relate to what the practitioner would actually do in a living specimen that gives us a meaningful finding, okay? So now we know that we have assumptions that are made from cadaver to living specimen, from coupled motion, from possibly static palpation or dynamic palpation, we don't know, to be transmitted into another system. So for muscle energy diagnostics to be correct, for the common Fryette model to be correct, like it requires the common Fryette model to be correct. If the Fryette model is not correct, then the vast majority of the claims in diagnostics made in muscle energy cannot be correct, okay? So we've got that as a starting point. Now, we're going to move to the next paper. This is, why did that not do what I wanted? The next paper is, I believe, I'm going to scroll up through it. It is Spinal and Sacroiliac Assessment and Treatment Techniques Used by Osteopathic Physicians in the United States. This is from a web-based survey using 5-point Likert scale, which is essentially completely disagree, disagree, neutral, agree, strongly agree, something like that. That was developed. That survey was emailed to 777 practicing osteopathic physicians who were members of the American Academy of Osteopathy. Responses in the frequently and always categories were combined for reporting purposes. Yeah, so that's actually kind of funny. That's not that good. Anyways, that's just a methodological thing, but the findings still are going to have at least some value to us. So what we have, as far as within the American context, within a survey-based context on a Likert scale, the finding is that most respondents documented spinal somatic dysfunction using Fryette nomenclature, where apparent position or motion preference are recorded using an abbreviation. So T5 is extended, right side bent, and right rotated, I believe, is how that goes. R for rotated, S for side bent. Yeah. Oh, weird. That's slightly different than I would usually see it, but that's okay. Anyways, the next thing that we get to, where's what I wanted? Hold on. Nope, that's not what I wanted. Okay. Nope, there we go. That's what I wanted. Okay, so please excuse the silence. I'm just bouncing around in the paper. So this is from the paper. Most respondents had knowledge of the Fryette spinal biomechanical model, which is 89%. 60% reported that the model was frequently always useful for diagnosis and treatment, although 21% indicated they commonly diagnosed motion restriction combinations that contradicted the model. The use of radiology and diagnostic imaging was low, with only 7% of respondents frequently always using imaging prior to delivering cervical OMT, with 3% using imaging prior to delivering OMT to other regions of the spine. Okay, so you have low use of imaging, right? Very low use of imaging of any form, at least within the respondents to this particular survey. You had a large amount of people using the Fryette model. So what you're going to have the opportunity to predict as a result of that is that the majority of the diagnostic is made with methods that are outside of the body. So the practitioner is either looking at, feeling, or moving, or some combination of all three, the patient, to develop a diagnostic. And they're thinking, or at least reporting, through the lens of Fryette. Now, you do have some respondents noting that the model commonly diagnosed motion restrictions, or with that model, they commonly diagnosed things that did not match the predictions of the model. So the coupling that they noted did not match Fryette. You don't know exactly what that means. You don't know if it was in the type 2, where it's heavily flexed or heavily extended. You don't know if it's in the type 1. You don't know. But you know that you have at least respondents saying that they found things that the model did not predict. Now, if you have practitioners from their environment of observation noting that the Fryette model is not giving them the information that it predicts, then you now have a broken model, at least from the perspective of the living patient and the living practitioner. You have some report that this model does not predict accurately throughout all its use, right? So your assumption that the Fryette model is correct is now null, right? So the Fryette model does not show itself correct in living practitioners and living patients all the time. So you have to reduce your confidence that it has predictive value or reject the hypothesis. So what I would say is essentially you have to reject the hypothesis, right? We'll go down a little more because there was something here in the conclusion, sorry. Osteopathic physician members of the AAO who responded to our web-based survey reported using blah, 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 blah. Nope. Respondents prefer subject. Nope, that's not it. Anyways, there is criticism of the Fryette model, and you can identify that simply through finding combinations that are not predicted by the model. Okay, so the model is not as strong as you want it to be in actual practice, so it loses its predictive capacity. Now we look at something else that is looking, this is not necessarily specifically within the osteopathic realm, this is more physical therapy. So that's the term that would be primarily used in America that would relate to what most people in other parts of the world will call a physiotherapist, essentially the same profession. Please excuse me. Okay, so this study is, does the evidence support the existence of lumbar spine coupled motion? Critical review of the literature, right? So methods and measures. Using OVID databases, we reviewed and categorized articles published between 1982 and 2006 that addressed coupled motion between side bending and rotation in the lumbar spine. We identified 24 articles in which 32 analyses addressed our clinical question. The results, 17 of the 24 articles identified concluded that some form of coupled motion exists. However, there's little agreement across articles as to the specific characteristics of coupled motion. The conclusion is that the inconsistency of reported patterns of coupled motion suggests that therapists should use caution when applying concepts of coupled motion to the evaluation and treatment of the patients with low back pain. So we have a meta-analysis of a bunch of printed research that just simply disagrees with the reporting of coupled motion. So once you identify that you don't have consistent agreement of coupled motion, regardless of what that coupled motion is, regardless of it's what you predict side bending right and rotating right, or side bending right and rotating left as your automatic or as your common. Once you see that disagreement in published research with varying methods, so varying ways to observe a living patient most of the time, possibly a cadaver sometimes, but you have little agreement, you know that the ability to predict the rest of the equation from one problem, or to see the common coupling, so essentially the prediction just doesn't hold, is null. You cannot accept it superficially. So sometimes you will see it, sometimes you won't. And what that tells you, very straightforwardly, is that the movement in one plane does not automatically predict the movement in the other planes, or the movement preference in other planes. So you know now that if you use the idea of coupled motion, that you're more paying attention to the idea than you are the obligate physical reality that your patient presents. So if you believe in coupled motion, if you assume that coupled motion is correct, you are far less likely to appropriately engage with your patient in the moment. This is a real problem, because if you make an assumption that the coupled motion that you agree with is there, you will miss something, right? So you have essentially committed an error in thinking, an error in diagnostic, and you will likely, as a result of that, commit an error in treatment that you will probably not detect because you believed you were correct and you didn't check. This is why I make the argument that osteopathy is a profession performed in obligate physical reality. It is performed in material reality. It's performed in shared reality. It is not well suited in its practice to be philosophical. Because if it's the realm of ideas, you prefer ideas over obligate physical reality, you will miss stuff. This is exactly how you commit errors. You don't check things that you need to check. You make an assumption, you take a shortcut, and you don't see what's there in the obligate physical reality. So you have to be very careful. And we have a meta-analysis that suggests that this is the case. So essentially, we have more and more reason to reject Fryette, or to even reject generally coupled mechanics, right? So the idea of coupled mechanics is something that we want to be careful with or avoid it altogether. The final paper that we're going to look at here is Primary and Coupled Cervical Movements, the Effect of Age, Gender, Body Mass Index, a three-dimensional movement analysis of a population without symptoms of neck disorders. So essentially this one, what we're looking at is checking how people are moving in the cervical column with the idea of coupled motion being present. Your results, so this is what we're actually going to pay attention to. Age influences the majority of primary and coupled movements, right? So as you get older, there's an influence on how you move, either the primary movement or the non-primary movement. With increasing age, primary movement size decreases in all cardinal planes. Age most strongly affects the coupled movements of primary rotation and lateral flexion. Gender and body mass index have only slight influences, right? So your most common thing that seems, at least in this particular experiment, to affect the motion of the neck is age. So as you age, you have less motion, generally speaking. The conclusion: coupled movements are a natural part of cervical motion together with primary movements and allow specific patterns in subjects with no symptoms of neck disorders. Study shows that cervical motion alters throughout life according to specific patterns, but with individual variations. So it's that individual variation thing. Individuals are different. So across a lifespan, we can see changes in motion capacity in one person, and then a different set of changes in motion capacity in another person, which tells you that you can't predict what it's going to be based on the coupled motion models. You know that age is going to change motion capacity, but you now know that it's going to change it in different ways. So we need to be very, very careful with that. So this all leads essentially to me being able to make the claim, again, that osteopathy is primarily performed in the realm of physical reality. It should not be performed as a philosophy. You can have a philosophy, you can have all those discussions, but don't perform it as such. Perform it as something that is material, that is in the realm of obligate physical reality.